Welcome to Bookfulness. This is number 18 in our series on clinically oriented anatomy. Last time, we were looking at the anterolateral abdominal wall.
Right, the container,
Yeah,
so to speak.
exactly. And today, we're finally heading inside into the abdominal cavity itself. And this is where things start getting really intricate, I think.
Oh, absolutely. If you thought the wall was complex, wait till you get to the peritoneum. It's this huge continuous membrane that basically organizes everything inside. It dictates where organs sit, how they move, and even how diseases spread.
Yeah, I remember this being a big hurdle for students. It's hard to visualize. So our goal today, our mission, is to try and clear that up. We want to unpack the peritoneum, its layers, its folds, its spaces, and then follow the path of the upper part of the digestive system. We're talking esophagus, stomach, small intestine.
It's a really foundational session. Honestly, if you get your head around the peritoneum, understanding abdominal problems becomes so much easier. It's key.
Okay, let's start right at the basics then. Definitions. We talk about the peritoneum as a lining, but it's two distinct things, isn't it? #tag. One, defining the peritoneum and peritoneal cavity.
That's the first crucial distinction, yes. You have the parietal peritoneum and the visceral peritoneum. The classic analogy, and it's a good one, is to imagine pushing your fist into a balloon that's not fully inflated.
Okay.
The layer of the balloon that's lining the inside of say, the box you're holding it in, that's like the parietal peritoneum lining the actual abdominal wall.
Right, lining the cavity itself.
Exactly. And the layer of the balloon that's directly wrapped around your fist, the organ, in this analogy, that's the visceral peritoneum, it invests or covers the viscera.
Okay, so parietal lines the wall, visceral covers the organs. Got it. Now, following that balloon analogy, what about the space between those two layers? The air inside the balloon, essentially. Is that the peritoneal cavity?
It is, yes. And this trips people up. It's not a big open space like a room. Under normal healthy conditions, it's what we call a collapsed potential space.
Potential space, meaning it's usually empty.
Pretty much.
Yeah.
It normally contains almost nothing except a very thin film of lubricating fluid. We're talking about maybe 50 milliliters total. Just enough peritoneal fluid to keep things slippery.
50 milliliters? That seems tiny for such a large area. Why is that little bit of fluid so vital?
It's all about movement and reducing friction. Think about your intestines. They need to churn, contract, move food along. That whole process is called alimentation.
Right, peristalsis and mixing.
Exactly. If those surfaces were dry or rough, they'd rub against each other, stick, maybe even tear. That tiny amount of serous fluid creates an almost frictionless environment, allowing all that complex movement needed for digestion to happen smoothly.
Okay, that makes sense. Now let's switch gears to something really clinically relevant. Sensation. You mentioned two layers, parietal and visceral. Do they feel things the same way? Because I remember learning there's a big difference.
A massive difference. And understanding this is key to diagnosing abdominal pain. It all comes down to the nerve supply. The parietal peritoneum, the layer lining the wall, gets its nerve supply from the same somatic nerves that supply the skin and muscles right above it.
Somatic nerves, meaning like the ones that feel regular touch, pain, temperature.
Precisely. So the parietal peritoneum is highly sensitive to all those things: pressure, pain, heat, cold, cuts. And crucially, because it's somatic innervation, the brain knows exactly where that pain is coming from. It's well-localized pain.
Okay, sharp, localized pain from the parietal layer. What about the visceral layer, the one wrapped around the organs?
Completely different story. The visceral peritoneum is innervated by visceral afferent nerves, part of the autonomic nervous system. These nerves aren't designed to pinpoint location or feel a light touch.
So what do they sense?
They're primarily sensitive to two main things: stretching or distension of the organ, and chemical irritation, like from acid, bile, or infection spreading onto the peritoneum.
So if you say, cut the surface of the intestine itself during surgery,
the patient feels nothing from the visceral layer itself. But if that intestine swells up significantly, or if irritating fluids leak onto it, then you get pain signals. But here's the catch. The pain is typically dull, aching, and very poorly localized. The brain doesn't get precise coordinates.
And that lack of localization leads straight into referred pain, doesn't it? Where you feel the pain somewhere else entirely, or at least in a general region.
Exactly. This is one of the most important clinical correlations in abdominal anatomy. The pattern of where that poorly localized visceral pain is felt depends entirely on the embryonic origin of the organ involved.
Embryonic origin.
Yes, specifically whether the organ developed from the embryonic foregut, midgut, or hindgut. The pain refers to the dermatome level corresponding to that origin. It's remarkably consistent.
Okay, walk us through that pattern. Foregut first.
Organs derived from the foregut, the stomach, liver, gallbladder, spleen, pancreas. The upper part of the duodenum when they cause visceral pain. It's typically felt in the epigastric region. That's the upper central abdomen, just below your sternum.
Epigastric for foregut. Okay, what about midgut?
Midgut derivatives. This includes most of the small intestine, the appendix, the cecum, the ascending colon, and about 2/3 of the transverse colon. Their visceral pain is referred to the umbilical region, right around the belly button.
Umbilical for midgut. Makes sense. And hindgut.
Finally, hindgut derivatives. The distal part of the transverse colon, the descending colon, sigmoid colon, rectum pain from these structures refers to the pubic region, also called the hypogastrium, that lower central area above the pubic bone.
Foregut epigastric, midgut umbilical, hindgut pubic. That's a pattern worth remembering. So let's take a classic example. A patient comes into the ER. They have this vague, dull pain right around their navel. What should be high on the doctor's list?
Based on that pattern, you have to strongly suspect something's wrong with a midgut structure.
Yeah.
And the absolute classic is early appendicitis.
Ah, right, because the appendix is midgut.
Exactly. When the appendix first gets inflamed and starts to swell, it stretches its visceral peritoneum. That sends those vague signals to the umbilical region. The patient feels discomfort around their belly button. It's only later, if the inflammation gets worse and actually irritates the parietal peritoneum lining the abdominal wall nearby.
In the right lower quadrant.
Precisely. Then the pain shifts and becomes sharp and localized to that classic spot, McBurney's point. But catching that initial vague umbilical pain is often the key to diagnosing appendicitis early, before it ruptures. Understanding referred pain saves lives.
Okay, that mapping of pain is crucial. Now let's tackle the 3D structure, the folds. This is where the peritoneum goes from a simple lining to this complicated system of supports and compartments. Let's start with mesenteries. How do these form?
It's actually quite logical if you think about development. Imagine an organ developing near the back wall of the abdomen. As it grows, it needs to push outwards into the main peritoneal sac.
Okay, it bulges into the balloon.
Right. But it can't just float freely. It needs its lifeline, its blood vessels, nerves, lymphatics. These structures originate from behind the peritoneum, often on the posterior abdominal wall.
So they have to follow the organ.
Exactly. As the organ pushes forward, it drags its neurovascular bundle with it. And as it does, it pulls 2 layers of peritoneum with it. One layer that was lining the back wall, and one layer that reflects back onto the organ. This double layer of peritoneum, sandwiching the vessels and nerves and connecting the organ to the posterior wall, that's the mesentery.
So the mesentery is essentially a peritoneal sandwich carrying the plumbing and wiring to the organ. And it allows movement, right? Like the small intestine is suspended by a huge mesentery.
Precisely. The mesentery provides that mobility, which is essential for the small intestine's function. But then you have other organs that start out with a mesentery, but then something changes and they become fixed in place.
Right.
These are the secondarily retroperitoneal organs.
Secondarily retroperitoneal, meaning they weren't always behind the peritoneum.
Correct. During development, organs like the ascending colon, the descending colon, and most of the duodenum actually have a mesentery attaching them to the back wall, just like the small intestine.
So why do they lose it? Why do they become fixed?
As the gut rotates and settles into its final position, the back surface of the mesentery for these specific organs gets pressed firmly against the parietal peritoneum lining the posterior abdominal wall. And over time, these 2 peritoneal layers fuse together and essentially disappear.
So the organ ends up stuck to the back wall, covered by peritoneum only on its front surface.
Exactly. It loses its mobility and becomes fixed or retroperitonealized. But it's called secondarily retroperitoneal because it wasn't like that from the very start. It acquired that position. This is different from primarily retroperitoneal organs like the kidneys, which develop behind the peritoneum and stay there.
Okay, that distinction makes sense. Why is knowing whether an organ is intraperitoneal with a mesentery versus secondarily retroperitoneal so important, say, for a surgeon?
It dramatically affects surgical access. If you need to get to a secondarily retroperitoneal organ, like the descending colon or the duodenum, you can often make an incision in the parietal peritoneum just lateral to the organ, in the pericolic gutter, for example.
And peel it forward.
Essentially, yes. You can mobilize it by dissecting in that fusion plane without actually entering the main peritoneal cavity where all the mobile loops of bowel are. This provides a relatively clean and safe way to access the back of the organ or the structures behind it, like the ureter or major vessels. Trying to access the same structures by going through the middle of a mobile mesentery-bound organ would be much riskier and more complicated. Their fixation offers stability and a defined surgical approach.
Right, that makes surgical sense. Okay, let's talk about the really big, obvious peritoneal folds now, the omenta,
Yep.
starting with the greater omentum. It's that large, fatty sheet hanging down, right?
It is indeed. It's often described as a large, apron-like fold of peritoneum. It hangs down from the greater curvature of the stomach, and the first part of the duodenum drapes over the transverse colon and the coils of the small intestine, and then folds back up to attach to the transverse colon.
So it's actually 4 layers of peritoneum fused together in parts.
Technically, yes, it starts as 2 layers dropping down and 2 layers coming back up, but these often fuse, especially in adults. And it's characteristically filled with variable amounts of fat, hence the fatty apron description.
What's its job? Is it just padding?
It does provide some cushioning and insulation, protecting the organs from blows and helping maintain core temperature, but its most remarkable function is its role as the policeman of the abdomen,
The policeman. I like that. Why the nickname?
because it's incredibly mobile and it seems to actively migrate towards any site of inflammation or infection within the peritoneal cavity.
How does it know where to go?
It's driven by chemotaxis. When tissues become inflamed or infected, say you have appendicitis or a perforated ulcer, they release chemical signals, inflammatory mediators. The greater omentum is loaded with immune cells, especially macrophages. These cells detect the signals and guide the omentum towards the trouble spot.
And what does it do when it gets there?
It literally wraps itself around the inflamed organ or the site of perforation. It then tries to seal it off by forming fibrous adhesions, sticky connections between itself and the surrounding structures.
So it's trying to wall off the infection, prevent it from spreading everywhere.
Exactly. It's the body's first line of defense, trying to contain a localized problem and prevent generalized peritonitis, which is inflammation of the entire peritoneal cavity and can be fatal. It's an amazing protective mechanism. When surgeons operate for something like appendicitis, they often find the greater omentum wrapped tightly around the appendix, confirming its policeman role.
That's incredible. Does the greater omentum include other named structures?
Yes, functionally, the term often encompasses the ligaments connecting the stomach to other structures that form part of this large fold. Specifically, the gastrocolic ligament, stomach to transverse colon, the gastrosplenic ligament, stomach to spleen, and the gastrophrenic ligament, stomach to diaphragm, are all considered parts of the greater omentum complex.
Okay. Now, what about the lesser omentum? It's smaller, right?
Much smaller, yes. The lesser omentum is the double layer of peritoneum that stretches between the lesser curvature of the stomach and the first part of the duodenum and the inferior surface of the liver.
So it connects the stomach and duodenum to the liver.
Correct. It has 2 main parts: the medial hepatogastric ligament, liver to stomach, and the lateral hepatoduodenal ligament, liver to duodenum. And it's this lateral part, the free edge of the lesser omentum, that's critically important.
The hepatoduodenal ligament. Why is that edge so crucial?
Because running within that free edge is the portal triad.
The portal triad. That's the hepatic artery, the portal vein, and the bile duct.
Precisely. The hepatic artery proper, bringing oxygenated blood to the liver, the hepatic portal vein bringing nutrient-rich blood from the intestines, and the common bile duct carrying bile away from the liver. These 3 vital structures are bundled together within this ligament.
Wow. So that small edge holds the lifeline to the liver. What's the clinical significance of that?
It's huge in trauma surgery, especially for liver injuries. If there's massive bleeding from the liver that's hard to control directly, a surgeon can quickly control the inflow by clamping the hepatoduodenal ligament.
How do they do that?
They can insert a finger behind the ligament through an opening called the omental foramen, which we'll get to. Hook the ligament, pull it forward slightly, and apply a vascular clamp. It's called the Pringle maneuver. It temporarily stops blood flow into the liver via the hepatic artery and portal vein, giving the surgeon time to find and repair the source of bleeding within the liver. It's a life-saving technique, and it relies entirely on knowing the anatomy of the lesser omentum and the portal triad within its free edge. ###3. Subdivisions of the peritoneal cavity.
Okay, so these folds, the mesenteries and omenta, don't just support organs, they also divide up the peritoneal cavity into different compartments. The main cavity is called the greater sac, right? But it gets subdivided.
Yes, the greater sac is the main, larger part of the peritoneal cavity, but it's effectively divided into 2 major floors or compartments by a horizontal shelf.
What forms that shelf?
The transverse colon and its mesentery, the transverse mesocolon. This structure runs across the abdomen, dividing the greater sac into 1. The supracolic compartment, everything above the transverse colon and its mesentery. This contains the stomach, liver, gallbladder, and spleen. 2. The infracolic compartment, everything below the transverse colon mesentery. This mainly houses the small intestine, the ascending colon, and the descending colon.
So like an upper floor and a lower floor. Does fluid move freely between them?
It can, but the transverse mesocolon acts as a partial barrier, directing the flow. Fluid dynamics within the abdomen are actually quite predictable.
Especially in that lower infracolic compartment, right? You hear about pericolic gutters and spaces that channel fluid. How does that work?
Exactly. The infracolic compartment itself is further subdivided. The root of the mesentery attaching the small intestine runs obliquely, sort of diagonally, down from left to right. This divides the infracolic space into a right and a left infracolic space.
Okay, and the gutters.
The pericolic gutters are channels running vertically on the outer sides of the ascending colon, the right pericolic gutter, and the descending colon, the left pericolic gutter. Think of them as vertical drainage channels.
How does gravity affect fluid flow in these spaces? Like if someone has fluid buildup, say ascites or pus from an infection.
When a person is upright or semi-upright, gravity pulls the fluid downwards. Fluid from the upper abdomen can track down the pericolic gutters into the pelvis, which is the most dependent part of the peritoneal cavity when sitting or standing. Conversely, if someone is lying flat or tilted head down, fluid from the pelvis can flow upwards along these gutters.
Is the flow the same on both sides?
No, and this is clinically important. The right pericolic gutter is generally wider and communicates freely with the space around the liver, the right subhepatic space, or Morrison's pouch, in the supracolic compartment.
So fluid can easily go from the lower right abdomen up to the liver area?
Yes. That's why infection originating low down on the right side, like appendicitis, can sometimes lead to an abscess forming up near the liver. The right gutter provides a direct pathway upwards.
What about the left side?
The left pericolic gutter is narrower, and its upward communication is partially blocked by the phrenicocolic ligament, a fold of peritoneum stretching from the diaphragm to the splenic flexure of the colon. This ligament acts like a small dam, often limiting the spread of fluid from the left infracolic space upwards towards the spleen and diaphragm on that side.
So understanding these gutters helps predict where infections or fluids might collect or spread?
Precisely. It helps surgeons know where to look for abscesses and helps radiologists interpret imaging. It's anatomy directly guiding clinical practice.
Now, besides the greater sac, there's another smaller, more hidden space called the lesser sac, or the omental bursa. Where is this located?
The lesser sac is a separate, smaller subdivision of the peritoneal cavity located entirely behind the stomach. It's also behind the lesser omentum and a portion of the greater omentum.
So it's like a hidden pocket posterior to the stomach.
Exactly. It's a potential space that allows the stomach to move freely against the structures behind it. It has extensions or recesses, a superior recess that goes up behind the liver towards the diaphragm, and an inferior recess that extends downwards between the anterior and posterior layers of the greater omentum, though this often gets obliterated in adults.
If it's a separate space, how does it communicate with the main peritoneal cavity, the greater sac? Is there an opening?
Yes, there's one single, relatively small opening called the omental foramen, also known historically as the foramen of Winslow, or the epiploic foramen.
The omental foramen, where exactly is it and why is it important? We mentioned it briefly with the Pringle maneuver.
Its location is key. It lies directly posterior to the free edge of the lesser omentum, the hepatoduodenal ligament containing the portal triad. So the portal triad is immediately anterior to the foramen.
What are its other boundaries?
Posteriorly, it's bounded by the inferior vena cava, covered by parietal peritoneum. Superiorly, it's the caudate lobe of the liver. And inferiorly, it's the first part of the duodenum.
And its significance.
Two main things. First, it's the only natural communication between the greater and lesser sacs, allowing fluid, like inflammatory exudate or blood, to potentially pass between them, although the opening is small. Second, as we discussed, its location just behind the portal triad makes it the anatomical landmark for surgeons performing the Pringle maneuver. They pass a finger through the omental foramen to hook the hepatoduodenal ligament in front of it. ###4. Clinical implications of the peritoneum.
We've touched on several clinical points already, but let's focus on some major issues involving the peritoneum. First, peritonitis and adhesions. Define peritonitis again for us.
Peritonitis is inflammation of the peritoneum. It's usually caused by microbial contamination bacteria getting into the normally sterile peritoneal cavity.
How does that typically happen?
Most often from a perforation, a hole in the gastrointestinal tract, a burst appendix, a perforated peptic ulcer in the stomach or duodenum, a ruptured diverticulum in the colon, or even penetrating trauma like a stab wound. These all spill bacteria-laden contents into the cavity. It can also result from infections spreading from other organs, like the fallopian tubes in women, pelvic inflammatory disease.
And because the peritoneum has such a huge surface area.
The infection can spread very rapidly, leading to diffuse peritonitis. The peritoneum absorbs bacterial toxins quickly, which can lead to sepsis, a systemic inflammatory response, and septic shock. It's a surgical emergency requiring prompt treatment with antibiotics and often surgery to fix the source of contamination.
Now, the body tries to fight this, like the omentum walling things off, but that healing process can cause its own problems later, right? That's where adhesions come in.
Exactly. When the peritoneum is inflamed or irritated, either by infection or even just by surgical handling, drying out during surgery, or contact with foreign materials like suture, it gets sticky. As it heals, fibrous scar tissue can form between adjacent peritoneal surfaces that aren't normally connected. These bands of scar tissue are called adhesions.
So the greater omentum might form them deliberately, but they can also form almost accidentally after surgery.
Absolutely. Adhesions are a very common complication following any abdominal surgery that involves opening the peritoneal cavity. They can form between loops of bowel, between bowel and the abdominal wall, or between bowel and other organs.
Why are they problematic? Don't they just sit there?
Often they do and cause no symptoms, but they can cause significant problems. Because the small intestine needs to be mobile, an adhesion can act like a tether. A loop of bowel might twist around that fixed point. This is called a volvulus. Or the adhesion band itself might kink or compress the bowel. Both scenarios can lead to a painful and dangerous mechanical intestinal obstruction, cutting off the passage of contents and potentially compromising blood supply to that segment of bowel. Adhesions are actually the most common cause of small bowel obstruction in developed countries.
Wow. So a consequence of healing can lead to a major problem down the line. Okay, let's shift to fluid issues. We mentioned ascites. Can you define that more formally?
Ascites is the pathological accumulation of excess serous fluid within the peritoneal cavity. Remember, normally there's only about 50 milliliters. In ascites, this can increase to several liters, sometimes even tens of liters.
What causes such a massive fluid buildup?
The most common cause by far is cirrhosis of the liver. Scarring in the liver obstructs blood flow through the portal vein, leading to high pressure, portal hypertension. This high pressure forces fluid out of the capillaries in the gut wall and mesentery and into the peritoneal cavity. Other causes include certain cancers that spread to the peritoneum, peritoneal carcinomatosis, heart failure, kidney failure, and pancreatitis.
And when someone has massive ascites, it causes obvious problems, right?
Yes, severe abdominal distension, discomfort, shortness of breath because the fluid pushes up on the diaphragm, and an increased risk of spontaneous bacterial peritonitis, infection of the acidic fluid. Often the fluid needs to be drained for diagnostic purposes to analyze the fluid, or therapeutically to relieve symptoms.
That drainage procedure is abdominal paracentesis. Where's the safest place to insert the needle, and what structure do you absolutely want to avoid?
The procedure involves inserting a needle or catheter through the abdominal wall into the peritoneal cavity to withdraw the fluid. A common and relatively safe insertion site is in the midline, through the linea alba.
Why the linea alba?
Because it's a fibrous band with very few blood vessels or nerves. You typically go slightly below the umbilicus or sometimes above the pubic zone, making sure the bladder is empty first to avoid puncturing it. The major vessel clinicians are always careful to avoid is the inferior epigastric artery.
Where does that run?
It runs vertically, deep to the rectus abdominis muscle, but just lateral to the midline in the lower abdomen. Puncturing it can cause a significant hematoma, a collection of blood, within the rectus sheath or the abdominal wall, which can be painful and sometimes requires intervention. So staying strictly in the midline helps avoid it. Other sites in the lower quadrants can also be used, carefully mapping out anatomy.
Okay. And finally, one more clinical application using the peritoneum itself for treatment. Explain peritoneal dialysis.
Peritoneal dialysis, or PD, is a really clever way to treat kidney failure by using the patient's own peritoneal membrane as a filter.
Instead of using an artificial kidney machine like in hemodialysis.
Exactly. Remember, the peritoneum is this huge, vast membrane. Its total surface area is almost equivalent to your skin surface area, and it's packed with tiny blood vessels, capillaries. It naturally acts as a semi-permeable membrane.
Meaning some things can pass through it, but others can't.
Right. In patients with kidney failure, waste products like urea, creatinine, and excess electrolytes build up in the blood, and they retain excess fluid. In PD, a special sterile solution called dialysate is infused through a surgically placed permanent catheter into the peritoneal cavity.
And what does the dialysate do?
The dialysate is formulated with specific concentrations of electrolytes and usually contains a high concentration of glucose, dextrose. Because the concentration of waste products, like urea, is much higher in the patient's blood capillaries within the peritoneum than in the dialysate, these wastes diffuse across the peritoneal membrane into the dialysate fluid, following the concentration gradient.
So the waste moves from blood to the fluid in the cavity.
Yes. And the high glucose concentration in the dialysate creates an osmotic gradient that pulls excess water out of the blood and into the dialysate as well. After a prescribed period of time, called the dwell time, usually several hours, the fluid in the peritoneal cavity, now containing the filtered waste products and excess water, is simply drained out through the catheter.
And then you put fresh dialysate in.
Exactly. The process is repeated several times a day or sometimes overnight using a machine. It uses the body's own internal membrane as the dialysis filter. It's a fantastic example of applying anatomical knowledge for therapy, allowing many patients more independence than traditional hemodialysis.
It really is ingenious. Okay, we've thoroughly explored the house, the peritoneal cavity, its lining, its compartments, its defenses, and even how we use it medically. Now, let's start looking at the inhabitants in the upper part of the house, beginning right where food enters the abdomen. The esophagus. The esophagus travels a long way down from the throat through the chest. We're interested now in just the very last bit, the abdominal esophagus. How much of it is actually in the abdomen?
It's incredibly short. After passing through the chest, the esophagus needs to get through the diaphragm to reach the stomach. It does this via an opening called the esophageal hiatus.
Where is that hiatus located?
It's typically found within the muscle fibers of the right crust of the diaphragm, usually at the level of the T10 vertebra. The esophagus slips through this opening.
And once it's below the diaphragm, how long is that abdominal segment?
It's only about 1.25 centimeters long, maybe half an inch. It's really just a tiny terminal portion.
What does it look like?
As it emerges below the diaphragm, it often widens slightly, sort of like the bell of a trumpet, before it joins the stomach at the cordial orifice. It lies in a groove on the posterior surface of the liver.
Now, this junction between the esophagus and stomach is critical for preventing reflux stomach acid splashing back up. But anatomically, there isn't a big, thick muscle ring like the pyloric sphincter at the other end of the stomach.
So how does the body stop reflux here? Is there a sphincter? There is what we call a physiological sphincter, meaning it functions like a sphincter to prevent reflux, but it's not a distinct anatomical muscle ring in the esophagus wall itself. The mechanism is actually quite complex and involves several factors.
What's the main component?
Probably the most important factor is extrinsic elongation. It comes from the diaphragm muscles surrounding the esophagus. The right crust of the diaphragm, which forms the esophageal hiatus, loops around the esophagus.
Like a sling.
Exactly. When the diaphragm contracts, like during inspiration, coughing, or straining, increasing intra-abdominal pressure, that muscular sling tightens, effectively pinching the esophagus closed at the hiatus. This diaphragmatic pinch is a major barrier against reflux.
So the diaphragm itself acts as the sphincter, more or less. Are there other factors?
Yes, the very oblique angle at which the esophagus enters the stomach helps create a flattening valve effect. Also, the folds of the gastric mucosa at the cardia might bunch up and help seal the opening. And there's the phrenicoesophageal ligament.
What's that?
It's a fascial membrane, an extension of the fascia from the underside of the diaphragm that attaches the esophagus to the margins of the hiatus.
What does it do?
It's important for anchoring the junction. It's elastic enough to allow the esophagus to move up and down slightly during swallowing and breathing, but it helps maintain the correct relationship between the esophagus and the diaphragmatic sling, ensuring that pinch mechanism works effectively. If this ligament weakens or the hiatus widens, it can contribute to a hiatal hernia where part of the stomach slides up into the chest cavity.
So it's a combination of the diaphragm's pinch, the angle of entry, and this anchoring ligament that work together to prevent reflux normally.
That's a good summary. It's a dynamic, multi-component system rather than a single anatomical muscle.
Okay, past the esophagus, we arrive at the stomach. This is probably one of the most shape-shifting organs in the body, isn't it?
Absolutely. Its size, shape, and exact position are incredibly variable. You can't just point to one spot and say the stomach is always here.
What factors cause that variability?
Several things. The most obvious is how full or empty it is. An empty stomach is quite contracted, maybe J-shaped. A full stomach can distend enormously. Respiration also changes its position. It moves down with inspiration as the diaphragm contracts. Posture matters too, whether you're standing or lying down. And significantly, the person's overall body type or habitus plays a big role.
Body type. How does that affect the stomach's position, say, on an X-ray?
In hypersenic individuals, people who are generally stocky, broad-chested, heavier build, the stomach tends to sit quite high in the abdomen and is often oriented almost horizontally, transversely across the upper abdomen.
High and transverse. What about the opposite?
In asthenic individuals, people who are tall, thin, slender, the stomach tends to be much lower, more elongated, and hangs almost vertically, sometimes extending way down into the pelvis when it's empty or it contains contrast material. It's much more J-shaped.
So you really need to consider the patient's build when interpreting images or planning surgery.
Definitely. Where you expect to find the stomach or a lesion in the stomach can vary quite a bit just based on their body type.
Yeah.
In most average individuals, asthenic, it usually occupies the upper left quadrant and might cross the midline into the epigastric region.
Okay. Despite its variability, we still divide the stomach into standard anatomical parts for description. What are they?
Yes, we typically describe four main parts moving distal from the esophagus. One, the cardia, a small area immediately surrounding the esophageal opening, the cardial orifice. Two, the fundus. This is the dome-shaped part that bulges upwards, superior, and to the left of the cardia. It usually sits right up against the left dome of the diaphragm and often contains swallowed air, visible as a gas bubble on X-rays. It can reach as high as the fifth intercostal space. Three, the body. This is the main largest part of the stomach, extending from the fundus down towards the narrower distal end. Four, the pyloric part. This is the funnel-shaped outflow region. It's subdivided into the wider pyloric antrum, which leads into the narrower pyloric canal. The canal terminates at the pylorus, which is a muscular sphincter controlling emptying into the duodenum.
Cardia, fundus, body, pyloric part, antrum, and canal. Got it. And the stomach also has two distinct borders or curvatures, right?
Yes, the shorter concave medial border is the lesser curvature, and the longer convex lateral border is the greater curvature. These are important landmarks, especially for blood supply and ligament attachments.
Internally, the stomach lining isn't smooth, is it? It has folds.
Right. When the stomach is empty, or partially empty, its internal lining, the mucosa, is thrown into prominent longitudinal folds called gastric rugae.
Why are they there?
They allow the stomach to distend significantly when you eat a large meal. As the stomach fills, the rugae flatten out, increasing the surface area and volume without stretching the wall excessively thin.
Are the rugae the same everywhere inside?
They're most prominent in the body and fundus. Interestingly, along the lesser curvature, the rugae tend to be less pronounced and more longitudinally oriented, forming a sort of channel.
A channel.
Yes, sometimes called the gastric canal or Mackenstrasse, German for stomach street. The idea is that this channel might allow liquids, especially water, to pass relatively quickly along the lesser curvature towards the pylorus, potentially bypassing solid food being churned in the main body of the stomach.
Ah, like an express lane for liquids.
Something like that, yeah. It facilitates faster emptying of fluids compared to solids. #7. Stomach relations and vital blood supply.
Let's think about what's around the stomach. It sits fairly anteriorly in the upper abdomen. What lies directly behind it? This area is sometimes called the stomach bed.
The stomach bed refers to the structures that lie immediately posterior to the stomach, but separated from it by the space of the lesser sac, omental bursa. Understanding these posterior relations is crucial because they are vulnerable if, say, a gastric ulcer perforates the posterior wall.
So what structures make up this bed?
The most significant structure forming the main part of the stomach bed is the pancreas, which lies transversely across the posterior abdominal wall. Other structures include the left suprarenal, adrenal gland, the upper part of the left kidney, the spleen, more laterally, and the splenic artery running along the superior border of the pancreas. The transverse mesocolon also forms part of the floor below.
The pancreas is right behind there. That seems important clinically.
Extremely important. A deep ulcer on the posterior wall of the stomach can erode right through the stomach wall and into the lesser sac. If it continues eroding posteriorly, it can penetrate the pancreas itself, causing inflammation, pancreatitis, or eroding into the splenic artery, which runs right along the top edge of the pancreas behind the stomach.
Eroding into the splenic artery sounds bad.
It can cause massive, potentially fatal hemorrhage, often contained initially within the lesser sac. Also, pain from posterior gastric ulcers or pancreatitis is often referred to the back because these structures are irritating the posterior abdominal wall nerves.
Okay, so posterior relations are critical. Now let's talk blood supply. The stomach has an incredibly rich arterial supply, doesn't it? Almost redundant.
It really does. It's one of the best vascularized organs in the abdomen, which makes it very resistant to ischemia, lack of blood flow. This entire rich supply comes from branches, originating ultimately from the celiac trunk, the first major unpaired branch off the abdominal aorta.
How is the supply organized? You mentioned the curvatures earlier.
The supply is organized around forming arterial and anastomosis connections along both the lesser and greater curvatures. It's like having two complete circuits ensuring blood flow.
Okay, let's trace the circuit along the lesser curvature.
Along the lesser curvature, you have the left gastric artery, which usually arises directly from the celiac trunk and runs down along the curve from the left. Coming up from the right to meet it is the right gastric artery, which typically branches off the hepatic artery proper, which itself comes from the celiac trunk. These two gastric arteries join end to end.
So left and right gastric arteries connect along the lesser curve. What about the greater curvature?
A similar pattern happens along the greater curvature, but with different arteries. Coming down from the left, originating from the splenic artery, another celiac branch, is the left gastromental artery, also called gastroepiploic. Coming up from the right, usually branching from the gastroduodenal artery, which comes from the hepatic, is the right gastroomental artery. These two also anastomose along the greater curvature, running within the layers of the greater omentum.
Wow. So you have the left and right gastric on the lesser curve and the left and right gastroomental on the greater curve, plus some short gastric arteries to the fundus from the splenic artery. That's a lot of supply lines.
It is, and the connections between these vessels are usually very robust.
What's the clinical significance of this incredible redundancy, especially for surgeons?
It provides tremendous surgical resilience. For example, during a partial gastrectomy, maybe removing the distal part of the stomach, like the pyloric antrum canal, for cancer or severe ulcer disease, the surgeon will inevitably have to ligate or tie off some of these major arteries, like the right gastric and right gastroomental arteries.
But the rest of the stomach survives.
Yes. Because of the excellent collateral circulation from the remaining vessels, the left gastric and left gastroomental, plus the short gastrics, the remaining part of the stomach usually has more than enough blood supply to stay viable and heal properly. You can ligate one, sometimes even two, of the main supply arteries without causing tissue death, necrosis, in the stomach remnant. This vascular safety net is a huge advantage in gastric surgery.
That's fascinating. It's like the stomach is built to withstand some serious disruption, maybe from evolution, dealing with rough food or injuries.
It certainly seems well protected vascularly, whether it's due to its acidic environment, mechanical stress, or potential for injury. That redundancy is a key feature of its design. It ensures this critical first stage of major digestion remains functional, even if part of its supply is compromised.
An amazing piece of biological engineering. Okay, we've processed the food in the stomach. Let's follow it past the pyloric sphincter into the next section, the start of the small intestine. The small intestine is where the real magic of nutrient absorption happens. It's incredibly long, but we divide it into three segments. The first part is short and distinct.
That's the duodenum. The name apparently comes from the Latin duodenum digitorum, meaning 12 finger breadths long, which is roughly its length about 25 centimeters or 10 inches.
And compared to the rest of the small intestine?
It's the first, shortest, widest, and importantly, the most fixed part of the small intestine. Most of it is stuck down.
Fixed. How so? And where does it run? It has a distinctive shape, right?
Yes, it follows a characteristic C-shaped course. It starts right after the pylorus of the stomach, at the L1 vertebral level typically, curves around the head of the pancreas, and then ends where it joins the jejunum at the duodenojejunal flexure, usually around the L2 level, just to the left of the midline.
So it wraps right around the pancreatic head. That makes sense, as that's where pancreatic enzymes and bile enter.
Exactly. The major duodenal papilla, where the common bile duct and main pancreatic duct usually empty, is located in the second part of the duodenum.
You said it's mostly fixed. Is any part of it mobile?
Yes, just the very first bit. The initial 2 centimeter or so, immediately after the pylorus, is called the duodenal cap, or ampulla. This part is smooth-walled internally, unlike the rest of the duodenum, which has circular folds, and it is mobile. It's still interperitoneal, suspended by the hepatoduodenal ligament part of the lesser omentum.
So the cap is mobile, but the rest isn't.
Correct. The remaining 3 parts of the duodenum, the descending, inferior or horizontal, and ascending parts lose their posterior mesentery during development and fuse with the posterior abdominal wall. So they become secondarily retroperitoneal, covered by peritoneum only on their anterior surface. This fixation makes them relatively immobile.
What are the pros and cons of being fixed like that compared to the freely mobile jejunum and ileum that flow?
Well, the fixation provides stability, ensuring the critical entry points for bile and pancreatic juice remain in a consistent location relative to the pancreas and biliary tree. It's probably less likely to twist on itself, volvulus, than mobile bowel. The downside is that its fixed position, especially where the third part crosses the vertebral column, makes it more vulnerable to crushing or shearing injuries in blunt abdominal trauma. It can't easily move out of the way.
Right, it gets pinned against the spine. Okay, just to be complete, what are the names of the four parts again, based on that C shape?
They're named pretty logically by their direction. 1. Superior part. The first part, including the mobile duodenal cap, runs backward and slightly up from the pylorus. 2. Descending part. Runs vertically downwards on the right side of the L1, L3 vertebrae. This is where the bile and pancreatic ducts enter. 3. Inferior, or horizontal part. Runs horizontally across the L3 vertebra, passing from right to left, deep to the superior mesenteric vessels.
Yeah.
4. Ascending part. Runs upwards and slightly to the left, leading to the duodenojejunal flexure, which is supported by the suspensory muscle of the duodenum ligament of Treitz.
Okay, after that fixed C-shaped duodenum, we transition at the duodenojejunal flexure into the rest of the small intestine, the really long coiled parts. The jejunum and the ileum. How long are we talking here?
Together, the jejunum and ileum measure about 6 to 7 meters long in a living person. They're longer after death when muscle tone is lost. They fill a large portion of the central and lower abdominal cavity, all suspended from the posterior wall by that large fan-shaped mesentery.
6 to 7 meters? That's over 20 feet. It's amazing it all fits. Now, for students, telling the jejunum apart from the ileum can be tricky. Is there a sharp dividing line?
No, there's no distinct line. It's a gradual transition. However, there are several characteristic differences between the typical proximal jejunum and the typical distal ileum that are important, especially for surgeons who might need to identify which part of the bowel they're looking at.
Okay, let's compare them. Where would you generally find each part?
The jejunum tends to occupy the upper left quadrant, ULQ, of the infracolic compartment. The ileum tends to lie more in the lower right quadrant, RLQ, and the pelvis, eventually terminating at the ileocecal junction where it joins the large intestine.
Location is a rough guide. What about the look and feel of the bowel wall itself?
The jejunum generally has a thicker wall and often appears redder in life. This is because it has more prominent internal mucosal folds, plicae circularis, for absorption and a richer blood supply. The ileum wall is typically thinner, less vascular, and paler.
Thicker, redder jejunum, thinner, paler ileum. What about the mesentery attaching them?
This is a really good distinguishing feature. The mesentery of the jejunum usually has less fat within it compared to the ileum. Because there's less fat, you can often hold the jejunal mesentery up to the light and see translucent windows between the blood vessels.
Less fat visible windows in the jejunal mesentery and the ileum.
The mesentery of the ileum typically contains much more fat. This fat often encroaches right up to the bowel wall, making it harder to see the blood vessels clearly, and you generally don't see those translucent windows.
More fat, no windows in the ileal mesentery. Okay. Now, the blood vessels themselves within the mesentery, you mentioned a classic difference in their pattern.
Yes, the pattern of the arterial arcades and the final straight arteries, the vasa recta, is probably the most reliable way to tell them apart, especially in an anatomy lab or surgery.
Describe the jejunal pattern first.
In the jejunum, the arteries coming from the superior mesenteric artery form relatively few, large arterial arcades, maybe just 1 or 2 layers of loops. From these simple arcades arise very long, straight vasa recta that go directly to the bowel wall. Think simple loops, long, straight vessels.
Simple arcades, long vasa recta for jejunum. How does the ileum differ?
The ileum has a much more complex vascular pattern. It features numerous short arterial arcades, often forming multiple layers of interconnected loops right close to the bowel wall. Consequently, the vasa recta arising from these complex arcades are much shorter. Think complex loops, short straight vessels.
Complex arcades, short vasa recta for ileum. Why the difference? Does it relate to function?
It likely does. The jejunum is the primary site for absorption, needing a very rich, efficient blood supply delivered relatively directly via those long vasa recta. The ileum's more complex, redundant arcade system might provide a greater safety margin against vascular occlusion, perhaps because it's dealing with slower transit times and potentially more bacteria as it approaches the colon. The redundancy ensures collateral flow if a small vessel gets blocked.
That makes sense. One more internal feature, lymphoid tissue.
Yes. While both have lymphoid tissue, The ileum, especially the distal ileum, is characterized by having numerous large aggregations of lymphoid follicles embedded in its wall. These are called Peyer's patches.
Peyer's patches in the ileum, what are they for?
They are a major component of the gut-associated lymphoid tissue, GLT. They constantly sample antigens from the intestinal lumen and mount immune responses. Their prominence in the ileum likely reflects the increasing bacterial load as you approach the large intestine, acting as an important immune surveillance station. Hashtag tag 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 10. Vascular and lymphatic pathways.
We mentioned the mesentery suspending the jejunum and ileum. It's this huge fan-like structure. Where does its base, its root, attach to the posterior abdominal wall?
The root of the mesentery is relatively short, only about 15 centimeters long, but it anchors that entire 6 to 7 meters of bowel. It attaches obliquely across the posterior abdominal wall, running from the duodenal junction, up on the left around L2, downwards and to the right, ending at the ileocecal junction in the right iliac fossa, near the sacroiliac joint.
So it runs diagonally from upper left to lower right.
Correct. And this oblique attachment is what helps create those right and left infracolic spaces we talked about earlier. The superior mesenteric artery and vein enter and leave the mesentery at its root.
Speaking of the artery, you mentioned it earlier, the entire blood supply for the jejunum and ileum comes from one major vessel.
Yes, almost exclusively from the superior mesenteric artery, SMA. It arises from the aorta just below the celiac trunk, passes behind the neck of the pancreas, and then enters the root of the mesentery. It gives off numerous large branches, jejunal and ileal arteries, that run within the mesentery to form those characteristic arcades and vasa recta supplying the bowel wall.
So the SMA is absolutely critical for the survival of the small intestine.
Critically important. Sudden blockage of the SMA, for example by a blood clot, embolus, is a surgical emergency called acute mesenteric ischemia, which can rapidly lead to infarction, that of large segments of the small intestine, if blood flow isn't restored quickly.
And the venous drainage, where does the blood go after picking up nutrients?
The veins leaving the jejunum and ileum mirror the arteries, eventually collecting into the large superior mesenteric vein, SMV. The SMV runs alongside the SMA in the mesentery root.
Where does the SMV drain?
This is key for liver function. The SMV typically joins with the splenic vein, draining the spleen, pancreas, and part of the stomach behind the neck of the pancreas. This union forms the hepatic portal vein.
The portal vein, so all the nutrient-rich but maybe toxin-containing blood from the small intestine goes straight to the liver first.
Exactly. All the absorbed carbohydrates, amino acids, water-soluble vitamins, and minerals enter the portal vein and are delivered directly to the liver for processing, detoxification, storage, metabolism, before the blood enters the general systemic circulation via the hepatic veins and IVC. It's the liver's role as a gatekeeper.
What about fats? Do they also go into the portal vein?
Mostly no. Most digested fats, especially long-chain fatty acids, are packaged into chylomicrons within the intestinal cells. These are too large to enter the blood capillaries directly. Instead, they enter specialized lymphatic capillaries located within the intestinal villi.
Ah, the lacteals. So fats take the lymphatic route.
Predominantly, yes. The lymph fluid within these lacteals, which looks milky because of the fat content, is called chyle.
Okay, trace the path of this chyle, this lymphatic drainage, from the lacteals all the way back to the bloodstream.
It's a stepwise drainage through progressively larger lymphatic vessels and nodes. 1. Fats enter the lacteals and the villi. Lacteals drain into lymphatic plexuses in the submucosa and muscularis layers of the bowel wall. 3. These drain into the first set of lymph nodes, the juxta-intestinal lymph nodes, located right along the mesenteric border of the intestine. 4. Lymph then flows along the arterial arcades to the mesenteric lymph nodes scattered within the mesentery. 5. From there, it collects into the superior central nodes, which are large nodes clustered around the origin of the SMA at the root of the mesentery. 6. Finally, the lymphatic vessels leaving these central nodes coalesce to form the intestinal lymphatic trunks. These trunks typically drain into the cisterna chyli, a dilated sac at the lower end of the thoracic duct, usually around L1, L2 level. 7. The thoracic duct then carries the lymph, including the chyle, all the way up through the thorax to empty into the venous system at the junction of the left internal jugular and left subclavian veins in the neck.
Wow, that's quite a journey. So fats bypass the liver initially and enter the general circulation directly via the thoracic duct.
That's correct. This lymphatic pathway is also critically important clinically because it's a major route for the spread, metastasis of intestinal cancers. Surgeons removing bowel cancer need to remove the associated mesentery and lymph nodes along this drainage pathway to try and catch any spread.
Let's wrap up the small intestine with a common congenital anomaly as something someone is born with. The ileal diverticulum, perhaps better known as Meckel's diverticulum. How common is this?
It's actually the most common congenital anomaly of the gastrointestinal tract, found in about 1 to 2% of the population, so maybe 1 in 50 or 1 in 100 people has one.
1 to 2%. That's quite a few people. What is it exactly? Where does it come from?
It's a remnant of the embryonic omphalloenteric duct, also called the vitelline duct. In the early embryo, this duct connects the developing midgut to the yolk sac. Normally, this duct completely closes off and disappears well before birth.
But in 1–2% of people, it doesn't fully disappear.
Right. A small part of it, the part closest to the ileum, persists as an outpouching from the intestinal wall. That outpouching is Meckel's diverticulum.
Where along the ileum do you typically find it, and which side does it stick out from?
There's a classic description often called the rule of twos, though it's approximate. It's usually found within about 2 feet, or roughly 60 centimeters, proximal to the ileocecal junction. It's often about 2 inches, 5 centimeters long. It occurs in about 2% of the population. It's twice as common in males. And critically, it always arises from the antimesenteric border of the ileum, the side opposite the mesenteric attachment.
Antimesenteric border about 2 feet from the end of the ileum.
Okay. If most people who have it don't know, when does it cause problems? Why isn't it clinically relevant?
Most Meckel's diverticula are asymptomatic throughout life. Problems arise typically in only a small fraction of those who have one, often in childhood, but sometimes in adults. The main issue is related to the type of tissue lining the diverticulum.
It's not just ileal lining. While it's an outpouching of the ileum, in about 50% of cases, the diverticulum contains ectopic tissue that doesn't belong there. The most common type of ectopic tissue found is gastric mucosa, stomach lining. Sometimes pancreatic tissue is found too.
Ectopic gastric mucosa. In the ileum, what does that do?
That ectopic gastric mucosa behaves just like stomach lining. It produces hydrochloric acid. This acid is corrosive to the normal adjacent ileal mucosa, which isn't protected against acid like the stomach is.
So it causes ulcers.
Exactly. That acid can cause peptic ulceration either within the diverticulum or, more commonly, in the adjacent ileum. This ulceration can lead to painless lower gastrointestinal bleeding, presenting as dark or red blood in the stool, which is the most common presentation in children. The acid can also cause inflammation of the diverticular itself, diverticulitis, mimicking appendicitis, or rarely, the ulcer can perforate, causing peritonitis. It can also sometimes act as a lead point for intussusception, telescoping of the bowel, or volvulus.
And the pain from Meckel's diverticulitis can mimic appendicitis.
Yes, very closely. Because the inflamed diverticulum is often located in the lower right quadrant, the pain, tenderness, and other symptoms can be almost indistinguishable from acute appendicitis. Surgeons operating for suspected appendicitis, if they find a normal appendix, will often run the distal ileum for about 2–3 feet to specifically look for an inflamed Meckel's diverticulum as an alternative cause.
So it's a classic cause of diagnostic confusion in the lower right quadrant. A perfect example of how developmental remnants can cause problems much later in life.
Precisely. It ties together embryology, anatomy, and acute surgical presentation beautifully.
That seems like a good place to pause our journey through the upper GI tract. We've covered a lot of ground, from the complex peritoneal linings and spaces to the esophagus, stomach, and the entire small intestine. Hashtag, tag C, outro. So to quickly recap this deep dive, we really got into the weeds of the peritoneal cavity, defining those parietal and visceral layers, understanding the potential space and the crucial role of peritoneal fluid. We traced how folds like mesenteries form, and the function of the greater omentum, the policeman, and the vital structures within the lesser omentum. We mapped out the greater and lesser sacs, the omental foramen, and the clinical importance of fluid flow in the pericolic gutters. And we covered conditions like peritonitis, adhesions, ascites, and how peritoneal dialysis works.
And then we move to the organs themselves. The short abdominal esophagus with its physiological sphincter, the incredibly variable stomach with its distinct parts, rugae, crucial posterior relations, and that remarkably resilient blood supply from the celiac trunk.
Right, and then through the pylorus into the small intestine, we detailed the C-shaped, mostly fixed duodenum wrapping around the pancreatic head, and then contrasted it with the long, mobile jejunum and ileum, highlighting those key differences in wall thickness, mesenteric fat, and especially the patterns of arterial arcades and vasa recta. We finished with the SMA supply, portal venous drainage, the lymphatic journey of fats via lacteals, and that clinically tricky Meckel's diverticulum.
I think the great takeaway is appreciating How the peritoneal arrangement, what's fixed, what's mobile, how things are compartmentalized, really dictates not just normal function, but also how diseases present and spread and how surgeons have to approach things. It's all interconnected.
Absolutely. It's a complex but logical system once you start to piece it together. Now, we've followed food down to the end of the ileum. Next time, we'll continue that journey into the large intestine, covering the cecum, appendix, colon, rectum, and anal canal. We'll also shift our focus slightly to look at some major accessory digestive organs that we've mentioned sitting nearby or behind the structures we discussed today, specifically the spleen and the pancreas. We'll save the liver and gallbladder for their own dedicated session after that.
Sounds good. The large intestine has its own unique features and clinical issues, and the spleen and pancreas are vital organs tucked away back there, with really important functions and relationships. Plenty more anatomy to explore.
We hope you'll join us for that next exploration. Until then, thanks for listening to Bookfulness.